Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, distinguished guys, ladies and gentlemen. Welcome to our Airlangga webinar conference series. And in this afternoon, we will talk about management of COVID-19 in pregnancy, antenatal to postpartum period, Western and Eastern experience. This topic is very interesting. So I will give a special to invite our speaker in this program. In this program, I will invite our speaker from Oxford, Dr. Manu Fatis, MA, that he will talk about management of pregnant in COVID-19 pandemic from Oxford experience. And Dr. Rafi Chandran Jiganakan, he will talk about management of pregnant women in COVID-19 pandemic in Malaysia experience. Also, and from Indonesia, we have Dr. Aditya Warman, obstetrician and gynecology PhD, that will talk about management of pregnant women in COVID-19 pandemic Surabaya experience. Ladies and gentlemen, why we talk about this topic? Because as you know, the COVID-19 pandemic is still a major topic around the world, including in Indonesia. As of 10 June 2020, the total number of COVID-19 patients in the country, in Indonesia, we have about more than 30,000 people that infected COVID-19. And while the number of world cases of COVID-19 is about 7.25 million. However, there is still not much information related to COVID-19 in pregnant and in women pregnant and their babies. So it's our responsibility as obstetrician and gynecology and also doctor that we have to learn a lot about this case. There is something that we have to know about how is the infection is that same from the ordinary adults in general, and how to diagnose in the pregnant women. Is rapid test useful, or we have to prefer CT thorax and swab? How is the development of the number of cases of pregnant women suffering from COVID-19, and how about the cure rate? Still a lot of things to discuss about how to manage a COVID-19 in pregnancy, antenatal to postpartum period in Western and Eastern experience. So, ladies and gentlemen, in this session, our program, first, I'm Dr. A.C. Madian Kurniawati, obstetrician and gynecology. I will open this program, and then we like to invite Professor Dr. Budi Santoso, obstetrician and gynecology, to give a speech from Faculty of Medicine, Universitas Airlangga. And then after that, I will continue and give the moment for our moderator, that's Professor Hendy Hendarto, Doctor of Obstetrician and Gynecology, PhD. So, in this session, I will invite Professor Dr. Budi Santoso, Doctor of Obstetrician and Gynecology, and after that, I will tell all about our role in this conference. So I give to Professor Budi Santoso to give any speech from Medical Faculty of Airlangga University.
Okay, thank you, Dr. Raiti. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. On behalf of the Dean of Faculty of Medicine Universitas Airlangga, who cannot join in this webinar today due to another important meeting, I would like to extend you all very warm welcome to Airlangga webinar conference series under the topic COVID-19 Management in Pregnancy, Antenatal, Post-Partum Period, Western and Eastern Experience. I also would like to welcome the distinguished speaker, Dr. Manu Fatis, Dr. Ravi Chandran Jeganathan, and from our medical faculty, Dr. Aditya Warman. Also the panelists, Professor Gasdecker from Adelaide University, Professor Eri Gumilar Dahlan, also Dr. Ernawati, medical doctor, PhD. Now in Indonesia, especially East Java, COVID-19 is still high. The impact, especially in pregnancy cases during this pandemic, need a special attention because basically the immunity of the pregnant woman is decreased and prone to the morbidity and mortality. This afternoon, we will listen to share experience about COVID-19 management in pregnant women in Oxford, as well as experience in Johor Bahru and also in Surabaya, East Java, Indonesia. We hope this webinar conference could improve our knowledge and skill, also give us a fruitful insight. Once more, I ordinarily want to thank to all speakers and panelists, Dr. Manu Fatis, Dr. Ravi Chandran Jeganathan, Dr. Aditya Warman, Professor Gasdecker, Professor Eri Gumilar, and Dr. Ernawati, who are willing to share the experience to us. It is really a good value for us. Last but not least, I would like to take this opportunity to express my sincerely thank you to organizer, to this concern, to this topic, and organize this webinar successfully. Enjoy this webinar conference. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Dr. Budi Santoso, Doctor Obstetrician and Gynecology Consultant. And ladies and gentlemen, at now I will give you some rules in Airlangga webinar conference series that all of us have to avoid this one. Okay, the rules is about how we can enjoy the conference and how do we get the certificate. And this one is the rule is full participation during webinar is required. So you have to stand by at this webinar. You cannot leave at the half of our webinar. By the end of this webinar, complete a survey form and write your name and title for the certificate. Notifying your presence in the chat room is not advisable and disturbing for other participants. Leaving the webinar room or disconnecting before webinar ends, you might need to re-register to rejoin. If you don't do that, you will not get the certificate. Next. And second is rules for ED accredited. Full participant during webinar is required, like what I see before. By the end of this webinar, you still have to complete a survey form. So I repeat this one and write your right name and title that you want to write in the certificate. The certificate will be sent to your registered email address. We will send you later. And how about rules for question and answer? You can use the question and answer box on the middle of your Zoom panel and write down your question. Open the participant window on the right side of the panel and click the raise hand button. Then wait for the panelist to allow you talk. Don't talk if the panelist not allow you. Do not ask in the chat box since it might be drawn by important announcement and other talks. And you must remark that question will be sorted and discussed after all lectures presented. Next. Okay, that's our rule for this Airlangga webinar conference series. You can enjoy this one. But before that, I will give all the moment to our excellent moderator. So I will invite Professor Dr. Hendy Hendarto, Obstetrician and Gynecology Consultant, PhD, to continue our program. Honorable for Professor Dr. Hendy Hendarto, Obstetrician Gynecology Consultant, PhD. We give time for you.
Thank you, Dr. Eti, for your excellent introduction. Assalamualaikum warahmatullahi wabarakatuh. Good afternoon, everybody. Welcome and thank you for joining Airlangga webinar conference series with the title today, COVID-19 Management in Pregnancy. There is something important that we give stressing in this topic, that is antenatal to postpartum period and Western to Eastern experience. I think it's interesting for discussion. And ladies and gentlemen, as we know, pregnant women are included in the category of a vulnerable people with high risk for contracting viral infection during the pandemic. And also we know that health care is essential service that should not be postponed or discontinued in the pandemic. So we still have to provide excellent obstetric service. And if necessary, maybe we need to create modification of the service with useful innovation during the pandemic. So in the context, talk about Western and Eastern experience, the first speaker for the webinar, Dr. Manu Fatih from Oxford University. Hello, Dr. Manu.
Hello, thank you. Shall I
20 minutes for presentation, please.
Okay, can you see my slides?
Yes, clear.
Okay. Well, look, thank you very much to the panel for inviting me, and I'm going to give a talk now on some of the things that we do in Oxford, and I'm going to structure the talk in the following way. So I'm going to give a little brief overview of SARS-CoV-2. I'm going to talk a bit about the general population infection figures, a little bit about the global pregnancy figures, UK pregnancy figures specifically, and the Oxford response. So in a very short period of time, we all went from knowing something about viruses to knowing quite a lot about one particular virus. And we're now very familiar with this single-stranded positive sense RNA virus. We all know about spike proteins and we all know about nucleocapsid proteins. What the interesting thing about this SARS-CoV virus is that it normally binds to a cellular receptor, is then taken into the cell, the RNA is released, then you have a RNA replication. The RNA is then assembled and packaged into fresh virus, and this virus is then released. And what we've learned over the last few months is that this cellular receptor is ACE2 largely. The other interesting thing that we've learned is that as you look at the pattern of infection, it's very clear that there are three stages of this infection. And what we see is the stage 1, which is the early infection, which is very common. So this is mild constitutional symptoms, fever and a dry cough with an associated lymphopenia. And this seems to affect almost everybody who has the disease. But then this disease, a large majority of people recover from this, and then a smaller group develop this pulmonary phase, which is where they become short of breath with hypoxia. And this is the group of patients who have abnormal chest imaging, they have the glassy appearance, they have transaminitis, and they have a low to normal procalcitonin. And in this group, there will be a group that require ventilation, and there'll be a group who are severely ill who require support but will get better. But similarly, in this smaller group of patients, so from the large to the small, there's another subgroup that develop a host inflammatory response phase. And these are the patients who get very sick, and these are the ones with the respiratory distress syndrome, shock, cardiac failure, renal failure. And this seems to be driven by a cellular response to the virus where the patient develops an extreme cytokine storm. And this cytokine storm with interleukin-6 and a number of other cytokines appears to drive the disease, microangiopathy, microthrombi, accelerated clotting and coagulation, and problems with elevated D-dimers and all the end organ damage associated with this host inflammatory response. And those are the patients with the severe renal disease, the severe cardiac disease, etc. And you see these elevated markers of CRP, lactate dehydrogenase, IL-6, D-dimers, troponin, etc. When we look at the general population infection figures, it's very clear that when we look at the original outbreak in the seafood market in Wuhan, and you can see that the speed at which this virus started to be announced, which was in probably the space of 2 or 3 weeks, where a novel coronavirus was officially announced, the CDC in China announcing a level 2 emergency response, the CDC in China then 2 or 3 days later releasing the viral sequence, and then creating reagents and probes and primers so that people could do PCR diagnosis. And what we learned from this initial outbreak is a little bit about the incubation of the disease. So the incubation of this disease is around about 5 days. This number that only people who were in infection and virology knew about greatly before was the R0 number, which is the reproduction rate of the virus. It appears to be 2.2 in this original outbreak. And certainly from the Wuhan, China experience, it was clear that the spectrum of disease showed that the majority of the disease was mild in appearance. And then there was a smaller subset, around 14%, that became severely unwell. And in total, there was 5% who were critical, who required respiratory support or developed multi-organ failure. In the UK, we had our first COVID cases reported on the 29th of January, and then we had the first coronavirus confirmed death on the 5th of March. And you can see that between the 5th of March and the 14th of March, we passed 1,000 cases. There was some injection of money, and people, the Prime Minister urging people to voluntarily avoid social gatherings. And then from the 23rd of March, which is actually 3 weeks after the first confirmed death, the UK was placed into lockdown with people only being allowed to leave their homes for limited reasons. And just 2 days before that, a lot of the schools, the pubs, restaurants were all closed. And you can see that if we look at the way that this, you can see the first death on the 5th of March, which is around about here, and you can see this rapid acceleration of deaths, and you can see the daily deaths sort of rising from here to actually quite spectacular levels of over 1,000 deaths a day. And as we move forwards, we can see this is starting to fall. I was very interested looking at Indonesia and looking at Australia, because I know that Prof. Decker is involved, and I thought it would be interesting to contrast the different patterns at which the disease has taken hold. And if we look at this slide, you can see that we can see that in the top row here, you can see the UK with this gradual rise of cases, as I just showed you. And then you can see this gradual rise in daily deaths sort of starting to tail off. If you contrast Australia, it's sort of plateaued, and you can see this modest spike and then a really rapid fall. And then you can see Indonesia, and you can see Indonesia is still on this upward rise, and you can see this pattern of daily deaths hasn't really reached this sort of classic distribution curve. I think what's most interesting is looking at the total deaths. And if you look at the numbers highlighted in red here, you can see that Australia was really rather spared this this virus with this axis showing 100 as the marker. You can see that Indonesia has 2,000 as coronavirus deaths as on the linear scale. And you can see the UK has been really rather badly hit with this integer being 40,000 deaths. What we realized in the UK and the general population is that there was a discrepancy in the way that the disease was affecting individuals. And so we realized that if you look at the population of ethnic minorities in the UK, the Asian population represents around about 3 to 5% of the total population, and the other races are smaller than that. But we could see a disproportionate burden of either contracting the disease and the distribution of critically ill COVID-19 patients. And you can see that in the Black and Asian minorities, you could see that the Asians were very badly disadvantaged with this virus and were much more likely, 3 times greater than their background population presence, to develop critical illness, similarly with the Blacks and other mixed races. When we look at the global pregnancy figures, the global pregnancy figures become a little bit more difficult. And the reason they become a little bit more difficult is that the way that the data has been gathered. So if we look at what is known, we have a problem here, which is that the data is limited. And so the levels of evidence are an issue. And what we would normally expect to see in levels of evidence is something that's peer reviewed, something that's an original research article, it's been well researched and published. And what we see in the literature is an enormous number of rapid responses or brief reports or correspondence or letters or preprints. And what that means is that we're also getting issues with a limited amount of geography. So what that means is that we're collecting patients, doctors who are working in particular hotspot areas where there's an awful lot of cases, like China, like New York, are able to gather patients together and actually produce data. And when we look at the pregnancy literature, there's actually, until quite recently, there's only 150 pregnancies that people are reporting on in actually diagnosed COVID. And many publications, at the last count, there was 30 or 40. And there's a question whether people are looking at the same patients in different ways, whether there's duplicate reporting going on. And it's very difficult to understand the nuances of what the conclusions of these data mean when there are relatively few pregnancies for them to base the conclusions on. When I looked in the literature, there's a very nice systematic review of 108 pregnancies. So this was in Acta Obstetrica and Gynecologica Scandinavica, which is, this is an open access article, so it's free to download. And what these authors did was reviewed all the papers and then decided to synthesize that data together to try and give it a sort of more cohesive view. And so when you look, you can see that what the papers show is that all the patients in these 108 come from 5 countries: China largely, Sweden, the United States, Korea, and Honduras. When we look at the breakdown of how these patients were managed, we see differences, but the differences are largely driven by the practice in China, because they've had the most amount of patients. So if you look at the mode of delivery of these patients, 92% of all these 108 pregnancies were delivered by cesarean section. And I think that speaks more about the management of pregnancy generally in China than it does about the specific management of COVID-19 in pregnancy. What we have learned is that the symptoms, or the presenting signs and symptoms in pregnancy, are largely the same as the non-pregnant. So the bulk of these patients have fever on admission, the cough, malaise, problems with breathing, dysmyalgia, and some patients present with diarrhea. The key other features are that the laboratory characteristics in these initial phases of disease are largely similar as well. So patients with COVID all have a large percentage have a lymphocytopenia, and the large percentage of them all have a large percentage have an elevated CRP. The interesting thing is that this was 108 confirmed SARS-CoV-2 patients. And actually in the literature, there is an awful lot of papers that say these patients were suspected to have COVID-19, but it's not confirmed diagnosis. So what can we conclude from the data on the whole population, the global population, of which there are hundreds of thousands of patients, is that we can see that the large number of patients have a mild disease, which is largely limited to a cough and a mild pneumonia. 15% of them have severe disease with dyspnea, lung infiltrates, and hypoxia, and 5% of those have respiratory failure, septic shock, and multi-organ damage. In the pregnant population, and as I said earlier, not all cases confirmed by PCR of this, but 108 are, we can see that actually there's a smaller number of severe patients and a smaller number of critically unwell patients. But there are reasonably strong associations between having COVID-19 and preeclampsia, as well as preterm premature rupture of membranes. And you can see that there's some logic to that. You've got a disease that is driving inflammatory status and a cytokine storm. It's also driving microthrombi and microangiopathy. And microthrombi and microangiopathy is associated with preeclampsia, so you can see an association there. And elevated cytokines are associated with driving fetal amniotic fluid membrane weakness. And so there's some biological plausibility to the associations between these two diseases. When we look at the UK pregnancy figures, we are fortunate that we have a system called the UK Obstetric Surveillance System. So this is a national system that's run from Oxford, from the National Perinatal Epidemiology Unit, by somebody called Marion Knight. And when the COVID-2 crisis hit, she co-opted 194 hospitals to start reporting on COVID patients. And we had 427 confirmed patients in this period of time. And the advantage to doing it this way was we could compare it with the background population delivering in the UK at the same time. And what the conclusion from that was that we were getting 4.9 COVID positive women per 1,000 pregnancies. And we could see that most were being admitted in the third trimester. What's interesting and reassuring, in the sense that the disease doesn't appear to be changing between different populations, is that the symptoms and signs of fever, cough, breathlessness, headache, diarrhea, they're all largely very similar. Unfortunately, what we could also see is that this ethnic disparity in how symptomatic and how unwell people were getting in the non-pregnant population was also being reflected in the pregnant population. So you can see here that the incidence per 1,000 pregnancies, if you're white, is 3.5, and if you're Asian or black is much higher. And the rate ratio you can see here is 1 if you're white, and you can see it's 4 if you're black, 4 if you're Asian, 8 if you're black, 2.7 if you're Chinese or other, and 2 if you're mixed. So the ethnicity does seem to play a significant role in how patients are susceptible to this disease. And it's not entirely clear whether these patients have existing comorbidities that may predispose them to it, or whether they're just more vulnerable to the disease. The other good piece of news, certainly from the UK, is that the number of patients requiring critical care was about 10%. So what we can see is that despite the fact that we have this number of patients coming into the system, actually the number of women requiring critical care was 10%. We had 1 patient out of the 427 who needed extracorporeal membrane oxygenation, and we've had 1 death, 1% death, so 5 deaths from this outbreak, of which 3 can be directly related to COVID, and 2, COVID was a contributing factor. What's slightly more worrying is this piece of research that came out of New York, where the problem that we're doing at the moment is that we're screening just the symptomatic women. And so, of course, we see a symptomatic woman, they have a SARS positive PCR, they are positive. And what they did here in New York was they had 215 women who were delivered between the 22nd March and the 4th of April. And they had 4 symptomatic women, 1.9% who were symptomatic, all who tested positive. But then they tested the 210 out of the remaining 211. So you take 215 women, you have 4 who were symptomatic, there's 211 left. And they tested 210 of those for SARS virus. And they actually saw that 13.5% tested positive for the virus, which means that 29 out of 33 are asymptomatic. And this is important for us working in obstetrics, because it means that the requirement for PPE it actually becomes more important, because unless you can test everyone, then you've got a substantial population of patients who are SARS-CoV-2 COVID virus positive, who are actually asymptomatic and actually remain asymptomatic. So only 3 of these 29 women developed a fever before discharge. So finally, let me talk to you about the Oxford response. So we were fortunate in that, well, we were fortunate and London was unfortunate. So London was hit very hard by COVID-19, and Oxford is about 80 miles away from London, and we could see the situation unfolding in London, and therefore could make preparations based on what was happening in London. And so we decided to dedicate delivery suite rooms as COVID delivery suite rooms. So in our hospital, we have 17 delivery suite rooms, and rooms 8, 9, and 10 were dedicated COVID rooms, which mean that they didn't need to be super deep cleaned between one patient and the next. All theatres were prepared for COVID, and I'm going to talk about that later. We realised that we were going to have our biggest problem with category 1 caesarean sections. So we updated our category 1 caesarean section pathway. We stopped all elective gynecology, so there was none. We stopped all routine antenatal clinics and developed telemedicine clinics for obstetrics and obstetric medicine, as well as for gynecology. And we reduced the amount of ultrasound. So clearly the fetal medicine patients who required ultrasound, but they were brought in, we had staggered appointments, and there was no waiting. They just came in, they had their scan, they left. We in Oxford do routine ultrasound scanning for all women at 36 weeks, and we stopped all that scanning because we thought it was too much of a risk. The other thing that we did, which made a significant difference, was we had no partners, no husbands, and no visitors in the hospital except for at the birth. So there's no visiting by anybody outside the time of birth. And the other thing that we did that was important was we developed a COVID rota. which was a second layer of standby doctors in case of anybody falling sick and had just coming off the rota very quickly. So we just doubled the on-call availability. So our preparation consisted of 4 areas, which was information, training, personal protective equipment, and drills. So our information, we had, this is a picture of our delivery suite. So we have a COVID-19 board where we updated the latest information, what we were doing, who we were isolating, who meets the criteria for testing, what PPE, and the PPE guidance in the UK changed because we had a shortage of PPE. So this data, this board changed almost on a daily basis depending on the availability of PPE. But having this unified board in the delivery suite meant that every doctor and every midwife and every nurse was operating on the latest guidance per day. We issued information and training on 2 kinds of PPE. So level 1 PPE was PPE for patients with respiratory illness. And this consisted of cleaning hands, aprons, masks, and gloves. And we were, then you had a pair, and this became your skin. So the apron, mask, and gloves becomes you. And then anything you do, you wear a second pair of gloves on top of that. We then had level 2, and level 2 was any aerosol generating procedure. And actually it became very clear that this was general anesthetics. And so in obstetrics, it was general anesthetics. So you can see that there are a number of different procedures here which can generate aerosols. Nebulizers are not aerosol generating, and we were reliably informed that diathermy was not aerosol generating, although we all didn't really believe that. So this was wearing masks or a respirator, eye protection, gowns, 2 layers of gloves. And in order to have the masks, wear them effectively, and I can see a number of the audience and the number of the panelists wearing masks, we had to be fit tested in Oxford. So this one consisted of me with a much better haircut because all the hairdressers in the UK have been closed for the last 12 weeks. This consisted of us wearing an FFP3 mask and then having a noxious chemical fired into this hood. And the idea being that if the mask is fitted properly, you shouldn't be able to smell the chemical. If the mask is not fitted correctly, then you can smell it, and that means you can be taught how to wear the mask more effectively. We were taught how to put on equipment, how to put on level 2 PPE, and I'm very happy for you to have these slides to help in terms of teaching and training. And we were practicing, and so the key is to not have to do this cold. And so we had packs where these gowns and these aprons and these visors were reused again and again. So different doctors the gowns would all be folded up, the visor would be folded up, and we were using them again and again and again just to get training. And so we didn't waste PPE. And you can see, and here I am, and one of my colleagues, ready for a COVID positive category 1 cesarean section. We were also told how to take off protective level 2 PPE clothing, and there's actually a very specific technique to do it. And you can see that actually this person on the left is taking off the mask incorrectly. These people on the right are taking off even the theatre hats and the shoes. And we had sections of the operating theatres, anaesthetic rooms, designated as dirty. And so you can see the red tape. So inside this, you would de-gown, de-robe, even the shoes would come off and everything would be sterilised. And then, and this was practiced again, not using fresh PPE, but using the same PPE. We changed the way that we used our corridors, and so we have 2 corridors, and we had a COVID corridor and a non-COVID corridor. And so if a patient needed to go to theatre, they would go down the COVID corridor if they were COVID positive, and down the non-COVID corridor if they were non-COVID positive. And and so and then we developed a COVID category 1 cesarean section pathway, and this is because it takes a good 10 minutes. If you're well trained, it takes 10 minutes to get into PPE properly and to be checked. And so you needed 2 teams. So you needed the delivery suite room, the delivery room team, who were going to get the patient ready for the section, and you needed the delivery suite team who would start getting ready for in the appropriate PPE. And so you would have 2 teams handing over so that the patient could have their category 1 cesarean section as quickly as possible. And I can tell you that this outfit and if we were doing the cesarean section with this outfit, you have to put another gown on top of this, like a surgical gown, and another pair of surgical gloves. So at the end of this operation, you needed hydration. I mean, you needed hydration, you needed rest. And so this COVID rota enabled us to allow enough staff to get people to hydrate and rest. So the UK was in lockdown, and what we found was that most pregnant women self-isolated. It looks like in the UK, the severe disease burden was low. The lockdown is now being lifted, and we are poised waiting for a second wave of infection. And so we're anxiously waiting for the trial results from a number of vaccine trials and therapies that are being done, not just in Oxford, but also around the world. I'm going to finish with an appeal. So we do have a study in Oxford, which is not a difficult study. It's an observational reporting study called Inter-COVID. And so this is a global study to assess the effects of COVID-19 in pregnancy. And effectively, the forms are done, the data requirement, the data collection, the forms are all done, everything is done, and it's not a difficult study. We have 28 countries currently taking part, and if you are interested in taking part in this trial, please make a note of this person's email and email them, and she'll contact you. And if you want to take part in this study, I would encourage you to do so. I'm going to finish now, and thank you very much for your attention.
Dr. Manu, thank you very much for your excellent presentation that talk about UK response to COVID-19 pandemic. Very interesting. Thank you. Ladies and gentlemen, now we continue to from Malaysia. Dr. Rafi, you have 20 minutes time for presentation, please.
Yes, wait, I need to share my files. Wait, I have to get my slides on, huh? Why can't I get my slides, huh?
Slide share.
Yeah, 1 minute. I'm getting my slide open. Okay. Can you see the slides?
Yes, very clear.
Okay. Selamat petang.
daripada Johor Bahru, Malaysia kepada semua. Now, I will share with you the COVID-19 Malaysian experience. Okay, as you know that Indonesia and Malaysia, we are very close. So I think there's a lot of things that we can learn and share. Now, you know that, that what we are going through now is something that we have never seen before. We have seen the first wave, the second wave. Now, we are just recovering, and hopefully there's no third wave, fourth wave, or anything like that. But whatever it is, it has caused a lot of disruption to economy, to the way we live, the way we practice medicine and everything. Okay. Now, the shadow that COVID has cast, there has been some good and some bad. The good is that we have suddenly realized that family is important. Suddenly we realize that we doctors and nurses have suddenly become the darling of society, because everybody thinks that we are the ones who are preventing the entire COVID virus getting out of hand. But of course, what we have to realize is there are sometimes an immediate effect that we have felt, and of course the delayed effect of COVID that you and I have yet to feel. So let's look at some of the local numbers that we have in Malaysia. As of yesterday, we have 8,336 confirmed cases, and yesterday there were 7 new cases, out of which 1,244 are still in treatment. Almost 7,000 have recovered, with 117 deaths. Now, if you look at the deaths by gender, obviously the female are less. So if female are less, obviously the pregnancy deaths are going to be less, and fortunately we have had none. So if you look in terms of the amount of examinations or investigations we have done, we have nearly done almost 600,000, out of which about 8,000 odd is positive, and 590,000 are negative, with a positive rate of only about 1.4%, which is very encouraging actually. So in Malaysia, what we did was, as the SARS began to unfold, we designated 7 hospitals specifically to manage this COVID patients. That means the moment this patient was positive, they would be transferred to these hospitals, okay? And these are the hospitals that functioned as COVID hospitals. And if you look carefully now, you will find, these are figures that was obtained 2 weeks ago. You will find that the capacity has reduced greatly, meaning the number of cases that are positive have reduced, and the number of overall COVID patients in Malaysia that are still seeking treatment in the designated COVID hospitals are very few. Now, the other hospitals that were not designated COVID hospitals, that were normal hospitals looking after a few COVID patients, this is what we call hybrid hospitals. And if you look in terms of the daily cases, you will find that we had a peak, then we came down, and then you see there's a peak coming up. Now, this peak is what we have picked up among foreign workers, most of them who are illegal, who have actually confined themselves into overcrowded living facilities. And they are now being isolated and being sent to a separate quarantine area, which is being looked after and paid for by the Ministry of Health, although they are illegal immigrants. And the whole aim of this lockdown was to flatten the curve. And if you look at it, we seem to have done it. And you know that as of June 10th onwards, we have actually liberated a lot of our economic sectors, as well as our recreational sectors, as well as our restaurants, etc. Even barbershops have been opened, but nevertheless, we are still under a semi-lockdown until the 31st of August. Schools are supposed to be open by end of this month. And these schools also will start with examination classes first, and the others will still have online learning that is still going on. And I must say that Malaysia, we have managed to flatten the curve to an appreciable extent, but only pray that this flattening will not suddenly bulge up again, because if we do not follow the SOPs, then this is what we anticipate may happen. Now, if you look at Malaysia, you'll find the majority of Peninsular Malaysia is in green and yellow, meaning the yellow means there are cases that are in recovery. There have been no new cases. Only in the red area, there have been new cases, which is confined to Selangor and Federal Territory, that is Kuala Lumpur. This is West Malaysia, and this is East Malaysia. So from what we were to what we are, we seem to be doing fairly well. Now, if you look in terms of pregnancy, in the 3 months that we have had a total of 57 confirmed COVID positive pregnancies. Out of this, 3 were delivered by vaginal delivery. 1 of these had a vacuum delivery. 15 had a cesarean section done. 36 are ongoing. And there were 3 miscarriages. Now, these 3 miscarriages, we are not at the moment able to tell, was it due to the COVID or was it due to other extenuating situations, because these patients had symptoms and signs that they were actually having a miscarriage, but because of the restricted movement order, they couldn't get to hospital in time. So we are not sure whether it's a direct cause of COVID or is it just an indirect cause because COVID caused the movement restriction. But what the good thing was, we did not have any significant maternal and neonatal morbidity or mortality. And I think that in a way was very reassuring for the Malaysian experience. So basically, what is the world like after COVID? So in Malaysia, these are some of the things that we had looked at to prepare us as we ease ourselves out of COVID, at the same time making sure that we do not get caught if COVID does decide to pay us a visit again. So we had to look at a lot of new norms, screening policies, and pathways. We actually have reduced the number of visits. We have reduced waiting time. We have one-stop clinic where the patient can go and have an antenatal visit done as well as other things done. I mean, if she's accessing a particular clinic for any ailment, let's say she's going there for cough and cold and she's pregnant, the doctor there will even do an antenatal checkup at that same sitting, even though she's not due, because we do not want her to come back for a repeat antenatal clinic. Now, of course, intrapartum care, Dr. Manu has very clearly told us how we have to change our practices. I'll share some of the changes that we have had. And of course, in postpartum care, in Malaysia, we have a system whereby we have 7 postnatal visits done by the health side to every postpartum woman who is at home. We have modified this and we have actually incorporated techniques of virtual consulting and virtual visits to help us overcome this. Now, laparoscopy are we revisiting, and I'm not going to touch on this because I think this is gynae, but you see we have changed. Just like how Dr. Manu looked different, these are some of my colleagues who are looking different, and look, we very much look like those oil and gas workers. Just because it's ONG, I think we all are in the same boat. Well, now we have to look at how we are modifying obstetric care. Basically now we have to look into re-looking at existing protocols. We have to make sure that we practice social distancing in the ward, social distancing in the labor room, social distancing in the OT. And this has actually come about where we have actually restricted the number of people who can be in an operation theater. We said there should not be more than 5 people in an operation theater, including the anesthetist, the assistant, the surgeon, his assistant, and the nurse who is actually scrubbed up. And more importantly is we have to look into mechanism of how to isolate patients who come in. Like for Malaysia and for Johor, we have a huge problem because we have a huge number, about 40,000 Johorians who work in Singapore who are in quarantine in Singapore. And every day they release 400 of them. And when they come here, until yesterday, we actually put them in hotels as quarantine. As of today, we are allowing them home quarantine, but nevertheless, they will be monitored using a tagging system. Now, when this patient who is at home on quarantine has an obstetric issue, say she's leaking or decreased fetal movement or she does have some bleeding, when she comes to the hospital, she'll be treated as a patient under surveillance. And there are certain procedures that you have to follow. And there are certain protocols and guidelines that you have to develop with your own practices to manage the situations. And then of course, we have to look at patients who have missed their appointments because of the movement restriction order. So this again has to be dealt with. And then of course, we have to look into the issues of domestic violence and a lot of issues happening because of people losing their economic ability to sustain. Husband and wife cannot get along because they've been spending too much time with them. So these are things that we have to, and we have actually picked up a slight increase in the number of cases of patients who've actually been exposed to domestic violence. And then of course, we also have to look into our husband-friendly labor rooms. In Malaysia at this present moment, we have actually put a stop to it, and we only deal it on a case-to-case basis, meaning we do not allow the next of kin to be with the mother in labor, because the other patients may be exposed, and it is something that we would want to prevent. And then, of course, we look in terms of medications. We feel there are no actual contraindications for steroids. Of course, we had some reservations with using non-steroidal anti-inflammatories. That is still lingering there. Now, hydrochloroquine has been told it's not safe, so maybe we'll not talk about that. So other modifications will be, not every patient who comes in with COVID at term needs to be delivered. Some of them we can wait for the 14-day period to go by, and then they can be just treated as a normal patient. So do not think that the moment the woman comes, it's a COVID positive, she's at term, we have to deliver. No, we can still monitor and decide otherwise. We have to look into incorporating technology and into helping our patients. Of course, there's no need to actually increase our ultrasound monitoring and things like that. But even then, when we do, please make sure that the ultrasound machine and the probes are thoroughly cleaned, okay? We can do CTG in labor, not an issue. And of course, we practice universal precautions in disposing the placenta. Now, what are the minimal standards for obstetric units that we have adopted in Malaysia? Again, we have written protocols. We have come up with national guidelines that I shared with Dr. Erna yesterday. And these guidelines are updated on a 3 to 4 weekly basis based on the current evidence that is unfolding. We have come up with doffing and donning techniques exactly like how Dr. Manu showed. The sad thing was we realized that we did not have enough isolation rooms or negative pressure rooms within the Ministry of Health in Malaysia. So this is something that we are looking at. We did not have a single negative pressure labor room in the entire country. In a country with about 500,000 deliveries, with about 120 hospitals offering obstetric services, it was sad to say that not a single one of us actually had a labor room that had negative pressure facilities. And what we did was we actually identified a designated OT for all COVID patients, and all COVID cases, whether they're obstetric, gynecology, or even non-obstetric and gynae cases, will use one single OT. And then, of course, we've also created a pathway where these patients will use in the hospital to minimize they contaminating other patients who are non-COVID. Now, these are some of the equipment that you have already seen. Now, this is very similar to what Dr. Manu showed, and as he said, I'm willing to share this, and we have actually very clear guidelines on what to use when. Even for our labor room nurses, actually midwives, what we have said is that we have actually created a special room with hot water and everything that if they feel they want to go and have a bath after delivery, all facilities are provided for them to do that. Now, other essential measures is, of course, we have to optimize staff, meaning do not have more than the necessary number, reduce the number of patients and healthcare givers that you will have walking around, and then we have to have a log tracking system for our staff so they know who was there in case they've been inadvertently exposed, because we had one of our university hospitals had to shut down the entire ONG unit because the staff actually were exposed to COVID from the patient, okay? And so these are things that you should avoid, more so in Indonesia when you have a huge population. And social distancing and personal hygiene must become the mantra for the day. It shouldn't just be something that we are doing now. I think it is something that we have to practice for a long time. We have to make sure that our patients and our doctors and healthcare providers' mental state is okay and they're coping well, because sometimes when they are stressed out working here, when they go home, they'll have issues. And of course, our occupational health system department was working overtime to make sure that any staff who had actually any symptoms were immediately dealt with. And we were very happy to tell you that the number of staff who actually got infected from a positive patient in the hospital was 0. The number of staff who got infected were actually from their own activities where they went for weddings and some religious functions and got exposed there rather than getting infected from patients, okay? And in fact, in my department, which I'm sure Erna and all know very well, I've started a 3-tier shift system in order to reduce the exposure risk. And of course, you have to change norms because a patient who would have been prepared for surgery before COVID, by the time they come for COVID, their risk assessment would have changed. So we have to make sure that patients are reassessed in a thorough manner. Now, these are some of the flow charts that we have developed to say how we are going to do it. This is a flow chart of ONG patients requiring admissions for surgery or delivery in a tertiary hospital. So this is how we have done it. So I can share this with you because I don't think it'd be fine for me to go through it with you now. Likewise, we have a flow chart for emergency and semi-emergency cases, how they will be risk stratified, how they'll be investigated, and how they will be admitted to the various wards that are available, and how, if they need surgery, how we will actually triage them into which OT they will go to. And again, this was for elective cesarean sections. Again, we will again classify them as low and high probability. We have the criteria to describe and prescribe patients into these two silos, and then we will deal with them accordingly. So I think it will be wise if you can come up with a system like this, because it removes a lot of ambiguity. And the most important thing, our staff are confident that if they follow this pathway, they are protected. And again, in a district hospital where we also have a mechanism, because you must know that district hospitals sometimes would refer high-risk cases to the tertiary center. So we have a mechanism whereby the moment they feel this high-risk case, we do not want them to be kept in a district hospital, but rather sent to us earlier rather than when the patient gets into trouble. So we had to come up with new policies. We now have a strict no visitor policy. That means no visitors are allowed unless it's on a case-to-case basis. Baby-friendly status have been modified. Birth companion status again has been temporarily suspended. Breastfeeding initially we thought was very difficult to carry out because our results took about 6 days to come. Now we can get our results within 24 hours. So this is the flow chart that we follow, meaning to say that it's a very short while the child may be deprived of the mother's milk, but as far as possible, we try not to stop the breastfeeding. You know, staffing, you have to make sure that as much as we want to look after patients well, we have to protect our healthcare workers. We have to protect patients, you have to protect other patients, and you have to protect the ancillary staff, especially those who are doing the cleaning and the scrubbing. They are the ones who are most exposed, especially after doing a COVID positive case in the OT. When they're contaminating the OT, the ancillary staff must be adequately protected. You must give important consideration for this. Now, social distancing, people have very many concepts. Sometimes the animal kingdom seems to have a better perception than us. And of course, in the way you're practicing your clinic setting has to change. These are the changes that we have done in our own department, where we have actually created space so that we try to incorporate that 1 meter space between patients. And we have unfortunately told that companions will not be allowed into the clinic setting unless there's a need to meet the partner to discuss certain issues. If not, we are not encouraging companions into the clinic. We are looking into extending clinic hours because we know that now we can see less patients per hour. So we're looking at whether we should create night clinics, whether we should create weekend clinics, whether we should create virtual clinics. So these are some of the things that are going on. Now, of course, you must realize as because of the nature of the disease, there's going to be a longer waiting time. So we're looking at outsourcing, whereby we are looking at buying into private hospital services. We are looking at opening our OTs throughout the week, meaning that means we may have a Saturday lease, a Sunday lease. We may extend our operating hours, which now closes from 8 to 4, maybe 8 to 8, 8 to 10. We may even bring in extra staff on a sessional or a voluntary basis to help us, okay? But we have to understand, because of the reduced numbers of doctors and nurses we can bring into OT, there may be an impact on the training or apprenticeship of trainees whom we have, because we have an interesting case. Cannot have, like last time, we'll have 10, 12 people trying to learn something, but now we can't do that. Of course, the most important thing is that we have to upgrade our facilities and equipment, and all this costs money. We have to give more empowerment to the patients so they become more involved in their home care. Home-based care is something we are looking at. And in fact, in Malaysia now, we are looking very seriously whether we should relook at domiciliary delivery, because at one time, more than 50% of deliveries in Malaysia was at home. Now it is less than 5%. Maybe with COVID, maybe it is time in the low-risk patient, we can rethink of allowing home deliveries with trained staff. Of course, we have to embrace technology, and I think today's presentation is a clear example of how we have embraced technology to address issues. Now, as we prepare for the future, when we are designing new labor rooms, should we look at negative pressure labor rooms? Should we have central monitoring systems? Should we have individual air conditioning so that we do not have an entire labor room that has only one huge air conditioning facility? And then of course our open wards have now to fulfill the norms of being 1 meter apart, which will mean that means we may need more requirements, we may need more space. Negative pressure labor rooms, OTs, etc. are something that we have to think carefully about. We even thought about, should we have a COVID complex? This is what we call a swabbing booth, where a patient will be brought here and the doctor here will actually use this to swab. This is what we have, it's called a swabbing cabin. This is a negative pressure cabin where we can swab 4 patients at one go. So these are some of the innovations that we have come up with in Malaysia. Of course, there are some new words that you and I have to learn: PPE, PAPR, mask, N95, KN9, all these things are new words. And as Dr. Manu mentioned earlier, airtight again is something. Last time airtight was just to make sure your biscuits do not become soft. Now airtight becomes a life-saving statement. We have to know what negative pressure is. I knew what donning was, but I did not know what doffing was until COVID came along. We have to know what is triple layer packing, because that is how we send the samples of COVID to the lab. Swab, when you say swab the patient now, you have to be very careful, because the houseman, when you say swab the patient, they might decide to do a high vaginal swab instead of an nasopharyngeal swab. Pus is no more the thick slimy fluid that comes out when you have infection. It is now patient under surveillance, patient under investigations. And these are some of the words that you and I have to make sure that it becomes a norm for us. Now, pandemics have no emergency, so we must make sure that we protect ourselves at all times when we are dealing with any patient who may be harboring COVID. Now, this is one of the infographics that we created and that we have circulated nationwide. The same thing that is in Bahasa, which I'm willing to share, no problems. Now, laboratory testing, initially we had a lot of problems because it used to take 6 to 7 days to get a sample result back, and hence it was very slow and tedious. But I must say that now we have come to a point where we can have the test result within 6 hours, okay? And then of course, if you're going to do any radiation, these are the risks involved. Now this is the RTK, which is a rapid test that we are talking about. Whether this is going to be a game changer, we do not know. But this is something that we are now using already in Malaysia. We are using this for our screening of pre-op cases, and also for patients who are coming in from Singapore to be placed under quarantine. Now, these are some of the admission criteria that we have come up with that you all can develop based on your own local scenarios. Now, this is the guideline that came out in early May. The next one will be coming out sometime in a week or two. So some of the key recommendations was, it's essential priority, and the way we are looking at the pregnant patient is the same. There's nothing added on at this present moment. We have to make sure that all our staff adhere to the guidelines of self-preservation. Screening of the PUI patient should be done as per guidelines that the Ministry of Health has come out with in the COVID-19 hospitals. We have designated hospitals and hybrid hospitals. And in the undesignated hospital, again, there must be a pathway and a mechanism for you to treat patient under investigation. And once they are confirmed, they are usually transferred to the designated COVID hospital. And in case they need a surgical intervention, then if there's no time for screening, then we'll prepare and we'll treat them with the full PPE or PAPR as and when indicated. Now, patient in labor, as what Dr. Manu said, we are offering Caesar, but now we are thinking that maybe we can take a seat back and consider looking at allowing vaginal delivery. So this is being given a rethink. Now, this again is not actually being considered, but breastfeeding, we are back in supporting it. Now, in view of current evidence coming very strongly saying that there's a thrombotic phenomena that is going, then we have to look at continuing VT prophylaxis if there are no contraindications. Now, so statement on the ONG services is the services should continue. Certain policies have to be suspended. We still do gynecological malignancy cases, whereas the other cold cases are being rescheduled. ART services has been at the moment been delayed so that as to focus the staff into managing the current workload of the obstetric patients. And these are some of the take-home messages that I think is that fortunately pregnant mothers do not seem to be at an increased risk. We have to modify our practices. We have to protect the patients and ourselves. We have to relook at existing protocols because that is very, very important. And I think an audit, maternal and perinatal morbidity and mortality is important. But so far, the 57 cases that we have had, we are quite lucky. We have not had anything significant. And of course, very important is rationalized intervention, and leadership and non-technical skills are very important. Now, these are some of the impacts that COVID has had. Of course, there's going to be a huge impact on budget because a lot of money will be going into the preventive aspects. The training of midwives and obstetricians are affected because a lot of apprenticeship part of it has been now dealt away with. So we have to relook at it. New design of facilities, especially labor rooms, have to be looked at. We may be looking at new investigation. Maybe COVID testing may become a prerequisite for every patient before they offered surgery. And then, of course, after the exposure, we must have standard operating procedure, how we're going to manage them. And of course, we have to look at medical legal issues, because what has happened now is that we have had a few patients with cancers who have actually died while awaiting surgery because we couldn't provide them with the care. So things like this will crop up. So just be prepared in order to manage this. I think documentation is of extreme importance in this COVID period. Okay, this is a new paradigm. Social distancing and keeping our distance is important. We, the healthcare workers, are carrying a huge burden, but I think nevertheless, that is something that you and I cannot run away with. Whatever we do, this is a fight that we cannot afford to lose. Thank you very much.
Thank you, Dr. Rafi. Thank you for the interesting presentation that talked about the current situation in Malaysia, that the distribution mostly in the green area.
Yes.
And with no mortality, no serious morbidity in pregnant patients. Excellent. Thank you, Dr. Rafi.
We are just lucky. We are lucky. We are lucky.
Yeah, thank you. Ladies and gentlemen, now we continue to the third presentation. Dr. Aditya Warman. Selamat sore, Dr. Aditya.
Selamat sore. Good evening, ladies and gentlemen.
Okay, Dr. Aditya is a senior staff in Department of Obstetrics and Gynecology, Dr. Stomo Hospital, Faculty of Medicine, Universitas Airlangga. Dr. Aditya Warman, you have 20 minutes for presentation, please.
Thank you, Professor Hendy. It's nice to join this discussion about COVID that we already meet every day. It started in mid of February that the government of Indonesian government announced about the COVID cases in Jakarta. It's 2 cases that in the short time, 2 cases is spread to the all region of Indonesia. Now, this is the data that I take yesterday, that there is 34,000 cases in Indonesia confirmed COVID. And the red one, the patient that dead is almost 2,000. Yeah. This is the graph that stated 3 days ago that in Indonesia, COVID is still increase, rising, and it's about 5 days ago that the case is 29,000 cases, that there is an increase of 5,000 in the 5 days. If you look in the figure, record time by time, there is a very high increases. The map in this figure okay, we skip this map is figure that in East Java, Surabaya is second highest incident of the COVID, and until now the graph is rising. Next, before, yeah, in Dr. Sutomo, we are a tertiary hospital in Surabaya, and the red one is the cases of patient, not only a COVID, but all the cases. Because of the tertiary hospital, we receive very severe cases that mostly should be entered to do intensive care. But in the 12 weeks, the last 12 weeks, we can see that in the blue line there is an increase. What kind of diseases come to Dr. Sutomo after we analyze that in the blue line is COVID. Of course, because there is no sign of the severity, many of them are in the mild of the COVID, and it makes our hospital have a burden in the services, because many of patients because of COVID come to our hospital, and then the bed is limited to severe patient. Slide. Yes. And then how our government respond to this situation? The first program is to screen, and the second program is to prepare the facility to receive patient. How the screen program is done? We have to mass program and mass screening to all the people, and the second one screening. How screening is done? How tools can be used to mass screening? We know that in the early 12 weeks, we know that our facility is very limited. So in the early weeks, we only screen by the risk factor, clinical appearance, or scoring system, and in the limited number using a serologist. Currently, in the 2 weeks or 4 weeks, the last 4 weeks, we have a serologist, rapid serologist test, IgG and IgM, and swab, and we can screen widely, even in the population, not only in the hospital, but in the population. Right? And the government published about the guideline to how to manage the COVID in Indonesia, right? And also our Society of Obstetrics and Gynecology released about the guideline, national guideline, and obstetric field, right? This is the figure of in the early 12 weeks. As you know, the history and history of contact, history of the traveling is used widely. Symptom and scoring also used widely, and rapid is very small number. Rapid IgG, IgM is small number, PCR is very small number. It noted that it stated that the PCR is less than 1%. And next. And also, we divide the person using probably, highly probably, and low probably. It called in Indonesia ODP and PDP. It's based on the clinical stage. The history of contact, traveling, febrile, and IgG, also NLR, and we decide if the patient is in the ODP, probably low or high. It's decide whether the patient to isolated, self-isolated at home or hospitalized. Slide. Next slide. This is early warning scoring that we use in the hospital. Recently, currently, we have a machine for the IgG, IgM more, and also PCR more, and we screen all the people in the population base and also in hospital. Right? So we prepare and set up all the room, delivery room, isolated room, set up a workflow, guideline, intensive care, and also preparing personal protective equipment for the health worker in the hospital, right? And also workflow in our hospital, there is a three kind. It also means that the red one is separated from the green one. Green area, red area is separated in the separated room, and in the middle we have yellow. It means that quite stateless. In the red area, all the worker, health worker, the doctor using PPA and complete PPA, and in the green area, all the worker using standard PPA. And of course, the yellow one. The yellow one is very, very dangerous, most dangerous area in the hospital. Why? Because in this area, the doctors should be decide the patient is in the state of infection or in the red area, sent to the red area, or non-infectious, do not have an infectious disease and sent to the green area. So we decide in the yellow area, all the doctors and nurse and midwife should using PPA, standard PPA, complete PPA for infectious disease, right? And 12 weeks, the last 12 weeks, we in Dr. Stomo, we have more than 500 cases, all, and obstetric 102 cases. We did a rapid IgG and IgM and 80 patients. There is a lack of 20 patients. Why? In the early of 12 weeks, we don't have any rapid machine, rapid tools, and also we have a machine for PCR, and there is a 72 cases from over 100, and from the PCR, there is a 20 pregnant woman is positive. In 45 cases that clinical state is high suspicious, after the swab, the PCR, 13 cases is positive. Right? If we look at the symptom and severity, we took care of 87 patients with the mild symptom, and all the patient is discharged alive and get well. And severe or the critical, we take care 12, one discharge with the cardiac disease, is comorbid cardiac disease. 8 patients died. Half of them is confirmed COVID and half is not confirmed. So the fatality rate is 67% in the critical patient. Overall, in obstetric case fatality, only 8%. Right? So with 100 cases, we start to analyze whether the clinical state have a benefit to screen our patient in the population base. Rapid IgM is good. Unfortunately, there is a cell 1, so we can analyze this. NLR, also we have NLR positive 11, sign and symptom, clinical sign and symptom positive 9, thorax X-ray that we did in the hospital is 9. Next slide. So there is some result here that clinical sign sensitivity only 47%, X-ray 96%, NLR 55%, IgM 93%, but there is a lack of weak of statistical analysis because there is one data, one cell is only one case. Early warning system and sensitivity only to 20%. So we still using all the clinical sign, and now we start with PCR if there is some sign of clinical sign positive. Next slide. Now we start with a case that we can maybe share and discuss. 2 or 3 weeks ago, we have a case, a twin pregnancy, 34 weeks of pregnancy, twin with severe feature of preeclampsia, with the laboratory result serologic positive, but swab PCR is negative. We did a cesarean section. What about the baby? After the swab from the baby, one baby is PCR positive and the second baby is negative. Slide. The second case is the woman, 30 years old, with the term pregnancy and previous section, and will be a session again. By preparing for the elective section, swab result is come, and the result is positive. We did a cesarean section and we explored the baby variant swab PCR negative. We swab in the maternal side of PCR negative, fetal side of the baby of the placenta, swab negative, umbilical cord rapid test serology negative, IgG, IgM, but umbilical cord blood swab is positive. It's very strange, and we can discuss by in this discussion. Slide. So, for completing our COVID situation, after we set up our guideline, set up of TPA preparation, we also modified our delivery chamber, delivery room, and also delivery chamber. We all the bed in the delivery room. Now we set up a small chamber with HEPA filter in the side, and we help to deliver like in the photos, in the picture. The nurse, the doctor, or midwife come and help the mother. And the right side is the doctor that prepare for the OT, like Dr. Mani and Dr. Rafi showed before. I think similar with the astronaut, but the astronaut will go to the moon, but the doctor will go to the OT. Next. Thank you for your attention. Thank you, Prof. Hedi.
Thank you very much, Dr. Aditya Warman, for the interesting presentation that talk about the data of COVID in Surabaya and also the experience how to manage the disease in the Dr. Stomo Hospital, Surabaya. Ladies and gentlemen, now we come to discussion session. We have a panelist, but unfortunately, we have just received the information that Professor Gas Dekker from Adelaide University cannot participate in the webinar due to some unexpected roster change. But no problem. We have two panelists now. Professor Eri Gumilar, we all know him. He has a senior staff in Surabaya and also the chairman of Indonesian Society Maternal Fetal Medicine. And also the second panelist, Dr. Ernawati, also a senior staff, and she is the coordinator of obstetric gynecology service in Dr. Stomo Hospital. Now we invite Professor Eri Gumilar as a first panelist to give question. Oh, no. Sorry. Dr. Ernawati first. Okay, Dr. Ernawati, please give a question or comment to the presentation. Please.
Thank you, Professor Hendy. Good afternoon, everyone, and good morning for Manu. Thank you for Manu and Rafi for joining this webinar. We are very happy that we know the data and how to manage COVID pregnancy in Oxford and also in Malaysia. If I can highlight from three presentators, that we saw that UK have the most number of COVID cases, and then we are number 2 and number 3 as Malaysia, but we have a different number of pregnant women with COVID. If we show from Dr. Manu presentation that they have 427 cases from whole country, and it's also 4.9 per 1,000 pregnant women. And in Malaysia, only 57 cases in whole country, whole Malaysia. But from Dr. Adit's presentation from Surabaya, we have cases with suspected and confirmed is 102 cases in only in Dr. Sutomo Hospital. So Dr. Raffi messaged me, don't jealous lah with the case. I'm
Don't
jealous
jealous.
with you because my ward is not enough for the case, but you only have 57 for the whole country.
Yeah, these are the confirmed cases. The confirmed cases 57, but the PUI cases we have thousands actually. You know, that's our problem. But I'm not jealous of you lah.
So what we can learn from here, if we saw from 3 presentator from the management, we almost have the same protocol to handle the COVID. But why in Indonesia we have a huge number of pregnant women?
Yeah.
And from the presentation, I can note that how to find the case from Oxford. They will test the patient if they got symptom or from history taking that they have a risk factor, and also in Malaysia. We also do this in Surabaya, but we still have confusing cases. So as Dr. Adit presentation, we screen all the patients. Since I think in the middle of April, we screen of the patient who will deliver in Dr. Sutomo Hospital with rapid test, and if the rapid positive, and then we will continue with swab test. And from this, the swab test positive is only about 20 until 24% from the cases. But if we analyze, if we do rapid test and then thorax photo and also laboratory examination, it shows that rapid test still have advantage because they have sensitivity about 70%, I think. But from 2 country, Oxford and also in Johor, you only do swab in suspected cases. So my question is to Dr. Manu and Dr. Raffi is it how you find cases in a pregnant woman if only from screen from symptom and history taking? Is are there some false positive or false negative cases in your management if only use not universal screening, I mean? So how to prevent this? And I think as you know, you see from the media that we have a lot of medical worker suffer COVID because of handling. But you, in your presentation, I think you have a lot of cases. Is it right, or you don't have medical worker got COVID from patient?
In Malaysia, we have got no case of a patient, I mean the healthcare worker getting COVID from a patient. All our healthcare workers who ended up with COVID, they got it from outside, either from a kenduri or some religious function or some birthday party or eating in the pantry, but not from the patient. So that was very encouraging for us that the preventive measures that we had taken worked. So that was good for us.
So I can echo that in Oxford as well. So actually the PPE, we had some staff who got ill when we had shortage of PPE. But as soon as we got adequate supplies of PPE, nobody got ill in the hospital. It was all from going to the supermarket or queuing or family. One of the 2 things that I think has changed is the PCR test. A lot of the PCR test is, you have to check who's doing the testing.
Yeah.
So there is a certain amount of technical skill. I'm just going to share a picture with you. This picture is where the swab, can you see this picture?
Mm.
So the swab actually needs to go here.
Yeah.
And actually what's happening is that we were able to audit some of the people doing the testing, and we had some people doing the testing who never had a positive swab, and that's because they weren't putting the swab far enough in. And then we had some people who were, you know, who were very effective. And so there's two separate things. So we train the people how to take the swabs, and then we change the way that we do swabs. So now every patient who's coming to the hospital is being tested. But the problem is, even with a really rapid turnaround, it doesn't help you if somebody's in labour. You're not going to get the turnaround as quickly as you would like. So you just have to use the PPE in a way that until you have a result. So if we have an elective cesarean section, we can screen them. We know that they're negative. It's all fine. But if you have a hot case and they come in and you have a swab, you don't know. You're just not going to get an answer in any meaningful time. The antibody tests have a 20% false negative rate. So so they're not the be all and end all. And the paper from New York that was in the New England Journal, which shows that you can have a large number of women who are carrying and asymptomatic. The immediate conclusion from that is that you just have to employ the standard infection control practice. You just have to assume. It's the same as when HIV came. You know, we had a test, we didn't have a test. You just assume everybody has HIV, and we have to do exactly the same.
So it's the key is PPA from the
and distancing. You know, I thought Dr. Ravi's talk was super. You know, it is the standard things that people have done from the time of Semmelweis, which is wash your hands, don't go from dirty to clean.
Yeah.
You know, it's standard stuff, and you know, we got so used to being okay with antibiotics, and you know, it's all fine. We got a bit lazy, and actually we have to and we just have to relearn things that actually we probably did a lot more assiduously before antibiotics.
Okay, thank you, Dr. Manu. I think Prof. Eri have any comment from the presentation?
Now, Professor Eri Gumilar, to continue with your question or comment to the presentation.
Good afternoon. It is our local time. So thank you for Prof. Hendy as the moderator. And I've been checking the time. Just will be ending until 6 p.m. Just only 9 minutes from now, I think. But I'm thinking for the solutions participants at the floor, I'm sure that they will be launching the questions to you all. Okay, yes.
You're muted.
Yeah. Can't hear you, Prof.
Your microphone is muted.
Okay.
Okay, it's okay now?
Oh,
right,
fantastic.
okay, thank you. Once again, thanks to Prof. Hendy as the moderator. And I'm checking now just the time to, I think just 9 minutes to 6 p.m. So I should just limit myself, since I've been thinking for a lot of participants at the floor. Of course, just they are very excited of your lecture, Dr. Manu and Dr. Rafi, and as well as Dr. Aditya, that we are very happy to be share of our own experience. Okay, but at least I can say that we are similar, that the whole world now, we always asking about when the disease will be ended. We are not sure. I'm attracted to Manu explanations. When we were in Oxford mid-February, me and Dr. Rena and Prof. Hendy, at the moments, I got some impressions in the UK that COVID-19 is underestimated, but that is so very attractive when you just repeat for the first death reported from the UK is March 5, and then 28 March, you will start, you start by your lockdown programs. I think just, we also, the similar experience. At the beginnings, we were not sure about the coming of COVID-19 in Indonesia, but the facts just tell the different story. And now just, I get some data about the UK first. The whole of positive cases now, almost 300,000 positive case from the UK and reported 40,000 death, total death, 40,000. Malaysia is 8,300 positive cases and total death is 118. And how about our national team now is 35,000 cases by 2,000 death. But again, we admit our limitations that we need the larger samples to be explored. That is our limitations. Just similarly to what Dr. Aditya has explained 2 months ago, we have started by a minimal level and then longer and longer look to be a better and better. And now we can report to you our daily sample had already been explored, just approximately 50,000 samples per day. So of course, just our hope by the larger samples, we will find the real data that we can do the, what is the testing, testing, and then the next steps to stancing, treatments, and then to make some evaluations. So just in short, the larger samples we need. And I just appreciate to these comparisons focusing to pregnancy. That yes, in Malaysia and Indonesia, I think just we just agree for the pregnancy servicings, we limited to make it be much rare to some visits, and we spend the telemedicines and make it the programs to be reduced for US scanning. But another attractive one from our figure for time beings in Dr. Sutomo, what Dr. Aditya explained here, the cases, even just only a few cases, but it's very hard to make some analysis and to draw the conclusion whether is the possibility of intrauterine transmissions. Once the woman becoming pregnant, and what is 3 months before until now, even collected cases have already been more and more, but it's very hard to think about the transmissions, the vertical transmissions from maternal to fetal can be proven later. But whatsoever, Dr. Aditya, one case by getting the umbilical cord and the placenta for the time being, yes, we will do for the next to be more cases. I think. And of course, just I limited myself for the time. We agree now just for the next step, what we should do here, while vaccines in the reality is still what is in the processing. It needs long process, long time, and of course, it's a long budget. And about the treatments, yes, just it looked varies the whole country. Singapore, just our neighbor, is very few victims. Malaysia is still good, but of course, as we wait, what is the definite treatment? That is we look for. That is our next burden on the shoulder to identify. While just again, after getting information from the whole world part here, we start be boring by lockdown. We are not bare by lockdown for 2 months. We wanted to be free and as soon as possible to be what is get to. That is so. Just in a short words, we don't want it more to stay at home. I think so that, and now just every country introduce the new normal life. But what exactly the definition of normal life, right? For like the South Korea, once declared is free from COVID-19, but it was not longer back again to the lockdown. So just another word is the second hit or the second wave. Just wait here. Okay, maybe I'm proposing to the moderator, since we have 1,000 participants, I think it's maybe giving chance for themselves to launching the question, I think. Thank you.
Yeah. Thank you. Thank you, Professor Heri Gumilar, for the discussion. We have a question, many questions from the audience in the chat box. I will read the question. The question for Dr. Manu. Whether the patient is still allowed to go to the hospital for antenatal care, is there any special procedure or regulation for the antenatal care?
We've tried to reduce the antenatal care, and a lot of the antenatal care is delivered by telemedicine. In fact, a lot of our postnatal care is delivered by telemedicine also. So the only time that the patients are coming to the hospital is if they have an acute emergency or they need an ultrasound scan, and that would be for fetal medicine reasons. So there isn't like a clinic anymore. Even the diabetic patients who usually come quite regularly, they're not coming to the hospital for their clinic, they are coming for the scan. And so we can find that media like Zoom is quite effective. Zoom or Skype or Teams, it's quite effective. And postnatally, we're giving people, antenatally, we're giving people home blood pressure monitors. They monitor their blood pressure at home. We give them dipsticks. They can dipstick at home. It's pretty, and the women are pretty motivated. They don't want to come to hospital.
True, very true.
Thank you, Dr. Manu. How about you, Dr. Rafi? Do you have a comment about the question?
Yes. In Malaysia, what we have done is something similar to what Dr. Manu has prescribed. The other thing what we have done is we have started sending our pakars to the peripheral clinic, the clinic near the patient's home. So they don't actually have to travel and come to the hospital to see us. They just go to the nearby clinic and our pakar is there to see them. So in that way, we reduce congestion in our hospital. At the same time, patient is looked after. But at the same time, a lot of things we are allowing patients to do at home. We are even now looking at asking patients to do MOGTT at home. Prepare the thing and give it to them, let them do it, and just send the blood sample to us from the clinic. So a lot of things can be done, provided you have motivated staff and patients who are willing to cooperate. If patient tak nak cooperate, sangat-sangat susah.
Thank you. Thank you, Dr. Rafi. The next question is, do you think straining and pushing during labor can produce aerosol? Dr. Manu, do you have a quick opinion?
No, we don't. So you can produce droplets, of course, but the mask and PPE should protect against droplets, but it won't produce aerosols.
Yes. Yep. So I tend to agree with Dr. Manu, but what we have done in Malaysia is we have stopped using Antenox as one of the analgesia because that tend to be aerolized. So we do not use Antenatal as one of the analgesias anymore. But for
that's interesting. We still do use it. So we put a filter. We put a filter on it.
Right. Yeah. So we were not so convinced with the filter, so we were just a bit concerned. And we also sometimes the laboring patient, we offer the patient a face shield as well. That means the doctor uses a face shield and the laboring mother also uses a face shield. So this actually prevents the droplets as well.
So we've just started that. That happened 2 days ago. So obviously you secured some more PPE. And so now patients as well as staff have to.
We have been using that for about 2 months now.
You must have a better supplier.
Yeah, no, we actually start doing it on our own actually. Yes.
Okay. Okay. One question from Dr. Ernawati, please.
Dr. Manu, if we compare your whole country data and pregnant woman data, it's a very few number of pregnant women suffer COVID. What is the key of the successful of to handle pregnant women to keep them safe from COVID? What is the key?
So we gave it instruction on self-isolation, and pregnant women listened. The non-pregnant women, everybody else didn't listen. So in the UK, we have 40,000 people dead because they didn't listen, and we have very few pregnant women dead because they did listen.
Is it the same to you, Dr. Rafi?
We just tell them that you don't want your baby to become ill. And then they follow what the pregnant mother, always baby comes first. So you tell them the baby can get ill, they will listen to whatever you tell.
Exactly right.
So that's what we do.
Okay.
Maybe you all should try the same trick.
Okay, another question from Professor Eric Gumilar.
Thank you, Dr. Mehdi. Thank you. You are go to Oxford and Johor, Malaysia. That in Indonesia, in sorting, we have a lot of cases of autoimmune on pregnant, lupus on pregnant.
Yes, autoimmune on pregnancy. So just lupus woman becoming pregnant. The problem is that before COVID-19's coming, the use or the span of corticosteroids, I think is we never think is the problem. But now, just I need your thinking here, since we realize that pregnancy is much easier affected by COVID-19. We know that women becoming pregnant by adaptations, they are just high risk for COVID-19. And then what is more, by giving them, lupus on pregnancy by corticosteroids, the simple questions, is it becoming what is contraindicate or just what is something? Dr. Manu and Dr. Rafi.
Are you asking if the use of steroids is contraindicated?
Yes. Just low dose or 5 milligram.
So steroids are being considered as a treatment for the disease, of course, and we have a trial called the recovery trial in which dexamethasone is being used as a treatment arm. There's no evidence, and we in Oxford we don't treat as many patients as the Evelina Hospital down in London, who specialise in autoimmune disease, but there's no evidence that it's making a difference. And I would say that there's this theoretical idea that the pregnant women are more susceptible to the disease, but it doesn't. And certainly from Dr. Ravi's data, and certainly from our data, that the actual degree of severity is not being mirrored. It's not. It's less than in the in the general population. And of course, we have a skew there because we don't have the right age matching. So of course, in the general population, everybody's like 65 or 75, and in the pregnant population, they're all much younger. But the level of severity doesn't seem to be so high.
Yes, Prof. Eri, I tend to agree with Dr. Manu, because even in our experience, the pregnant women seem to be actually faring better than the so-called general population. So we actually have got no issues in giving steroids, but as long as they are being monitored properly in the tertiary level center, I think it's okay.
Well, just thank you of your both opinion here that we are cooperate to internal medicines for every woman with lupus, how to get a cure within 6 months before becoming pregnant. That is, we wanted to see themselves to be steadier. That is maintained by a low dose of prednisone. And then now the questions, the woman's by her own right to be pregnant. That is the questions in the COVID-19 here, whether is prednisone should be carried out during the pregnancy or just look at contraindicate. I get it from another developing countries with the same problem. Of course, just they believe once becoming pregnant, absolutely just need small doses. But another paper now make revisit to the questions is tend to say the danger by giving this one. So that is, it attract me to, yes, I invite you all your opinion. Thank you. Thank you.
Thank you. Thank you, Ari.
In the chat box, is there any further study that explain why do risks seem to be contributing factor to contract COVID-19? And is there any genetical susceptibility based on the epidemiological study?
No. So this is a very interesting. This is a very interesting piece of either biology or on susceptibility or epidemiology. And actually, you know, where you have such a variance of infection and such a variance of mortality, even in the non-pregnant group, what that tells you is that there needs to be some very careful data collection in Indonesia, because you may find that actually there is an underlying susceptibility to disease, or there is some comorbidity that's linking it. But you know, understanding what those are requires a collection of data from those patients and probably collection of samples.
Yep. I think it's still too early to make that linkage at the moment.
Yes, I agree. I think it's you know, but we just need data. I mean, you know, we're making decisions and conclusions on papers, and I look at papers in the Lancet with 9 patients, and I look at papers in New England Journal with a couple of 100 patients. So we're not making informed decisions. We're making decisions based on very small numbers of patients.
Okay. Professor Eri Gumilar, when you have a comment? Yeah, it attracted me to be sharing for answering. I remember, Dr. Manu, 1 month ago, I got the news from Cambridge. The team had succeeded to discover the variant of COVID-19. By means, just there are 3 variations based on genetic from the COVID-19. So just stand on this point, we hope to understand about why just ethnicity susceptibility may arise from here. Or just for the vaccine maker will be much more difficult to design what is the best vaccines by the variety of gene of COVID-19. That is.
So I think there are some commonalities of viral structure, and there's some variants of viral structure. So I think the RNA inside is variable, but I think the spike is rather conserved. So I think techniques designed to attenuate or vaccinate the spike protein on the surface are probably more likely to be effective than something like the Moderna trial, which is using a microRNA in the US. And I'm sure that that microRNA would be very effective against that particular strain, but it might not be as effective with a strain with a different genetic sequence. But I think that the spike protein probably, I mean, they don't change usually. And actually, the evidence is that, not for COVID, but for general viruses, is that they usually become less virulent. So become more infectious and less virulent as time goes on, because it's a more effective way for the virus to propagate itself. So, so you know, and there are some reports in New York that actually they're seeing that it's being more transmissible but less lethal.
Less lethal.
Okay. I think this is a great discussion and interesting discussion from all participants here, from Dr. Manu, Dr. Rafi, Dr. Aditya Warman, Prof. Eri Gumilar, and also Dr. Enawati. But if we look at the schedule, we know that time is limit our discussion. So the conclusion of our discussion about the Western and Eastern experience, there are three conclusions. First is both have similar protocol but different facility and budget. And the second, stay safe for the health worker. And the last but not least, don't give up and keep safe our patient, pregnant women. Thank you. And I give back the time to the host, Dr. Eti. Dr. Eti, please end the webinar.
Okay. Thank you to Professor Dr. Hendy Hendarto, Dr. Obstetric and Gynecology Consultant. So, ladies and gentlemen, when the moderator give a time for me, it means that this session is finished. And now we will cut the last session. That's a closing session. And for the closing session, I would like to thanks to our speaker. There is Dr. Manu Fatis from Oxford and Dr. Rafi Chandran Jikanathan from Malaysia, Dr. Aditya Warman from Surabaya, and also for our panelists, there is Dr. Ernawati and Professor Eri Gumilar Dahlan from Surabaya too. We hope our session about management of COVID-19 in pregnancy, antenatal to postpartum period, Western and Eastern experience will be useful for all of us. That always find a patient with a pregnancy that still have possibility to get the COVID-19 infection. And ladies and gentlemen, to all participants, I'm as a master of ceremony also say thank you because all of you still in this webinar. And also I will say sorry if there is some mistakes that I have been done or I have been speak during this session. Ladies and gentlemen, for the next, tomorrow we still have any webinar that also interesting. You can register from now and tomorrow we will see again with the interesting topic too. So for the end, I will close this webinar, and for all the participants for Airlangga webinar conference series, you can get the certificate and we will send to your email. Okay, thank you very much and Assalamualaikum warahmatullahi wabarakatuh. Thank you very much.
Thank you. Bye-bye.
Cari foto ya. Foto.